periodontal disease? What are the things that we look at when we're doing staging and grading that we're talking about, okay, this is definitely gonna put somebody more at risk for having periodontal disease or it advancing? Smoking, what's the other biggie? Diabetes. So those are, for somebody to have that, doesn't necessarily mean that they're gonna get it, but it puts them at a greater risk, right? There's other risk assessments that we do when we look at caries. So you're doing those right now with your nutritional analysis, right? You're looking to see what their risk factors are for developing caries or for it to be more developed faster. We do oral cancer screenings with your EOE and IOE. Somebody who smokes or drinks alcohol puts them at more at risk for developing or getting oral cancer. We talked about periodontal disease, their history. If they've had periodontal disease in the past, that puts them at greater risk, right? The different behaviors that they have, of course, the bacteria being there. There's others which we all have car insurance and different types of insurance. They're risk assessing you. They say if you're a guy at a certain age that you're more risky, right? So those are all different risks, risk assessments that we have. The purpose of your risk assessment, of course, you want to develop or modify your treatment plan. When we talk about somebody being at greater risk, if they smoke and we know that they smoke, that's something that we need to talk to them about, because that may modify how we provide their treatment. So we're going to use their own risk factors to educate them. Obviously, you're not going to go into a spill about diabetes or smoking for somebody who doesn't have either of those risk factors. So you're using their risk factors to educate them about the potential oral health problems that they have. We want to provide factual information. Where do we get factual information from that we've been talking about for the past few weeks? Your credible sources, your peer-reviewed literature that you use, so you're going to provide them factual information, relate their oral health findings back to their behavioral habits. Okay, if they've got advanced periodontal disease and you know that they smoke, you know that they have these other risk factors, bless you, you want to relate what you're finding in their mouth back to those habits that they have and make modifications to those. Source and selection of risk factors. So how do we know what risk factors they have? We've gone through their medical history, we've gone through their dental history, their social history. These are the reasons that we ask, you know, if you drink, how often are you drinking? If you smoke, how often are you smoking? We're not just being nosy into their life. There's a reason behind asking those things. The clinical examination that you do, your radiographs, all of those things are the sources that you are using to decide on what their risk factors are. And then of course it goes back to what we were talking about, again, their patient's perception and how that plays into their values, their habits, the different experiences that they have, all those things go into your risk assessment. So when we talk about risk factors, by definition, those can be any exposures to their behaviors, their lifestyle, genetics play a part into that, any conditions, any systemic conditions that they have, that when those are present, that's the likelihood, again, that probability that they're going to develop that disease. This influences their susceptibility to that disease. The number and type do modify the onset or the degree or even the severity of the disease. For example, if somebody tells you they smoke, what is one of the questions we ask them? How much? Maybe how long have you been smoking? That's a good assessment, because somebody who maybe only smokes, you know, 1 or 2 cigarettes a day, or maybe they only socially smoke, that's different than somebody who's been smoking since they were 12 years old and they smoke a pack a day, right? Like that affects the progression as well. Again, that exposure to the risk factor, for it to be called a risk factor, the exposure to that risk factor has to happen before they develop the disease. So we would say that there's an association. If they've been smoking since they've been 12 years old, then that happened prior to them developing periodontal disease. And again, it's directly related to that disease occurrence. So there's 2 different categories. I'm sure you remember seeing on your pink sheet, modifiable and non-modifiable. And we're going to go through these, but Modifiable, obviously, it can be modified, it can be changed. Those can be environmental or behavioral. What's a behavioral modification? What's something that they can modify that they might do? Smoking, yeah, drinking, those different things are behavioral. Environmental, does anything come to mind environmental wise? We won't talk about some of these, but see if you're thinking this morning. We'll go into them in a minute. No, okay. Non-modifiable, again, those are things that cannot be changed, so that's intrinsic to the individual. So different conditions, they have diabetes, we can help control that, but different conditions they have, they're also referred to as risk determinants. But again, we're gonna go through some of these. Identification of those, different studies show that there's a strong association with certain risk factors in the development of the disease. And studies also show that elimination of that risk factor is beneficial to the patient, obviously. If we can get them to stop smoking or we can get their diabetes controlled, those are things that will change that outcome. Okay, so risk indicators and risk markers. So indicators, by definition, a lot of these same things, exposures, behaviors, lifestyle, genetics, conditions, all of those things are associated with the risk for the disease, but evidence does not support conclusively the association. They may just be probable risk factors. So by definition, a risk indicator it is likely that it is associated, but it is not definite. And then a risk marker is the other terminology that you want to distinguish between, but these are predictors for disease occurrence. So again, we're gonna look through some of these. So before we go further, take a look at the list, modifiable and non-modifiable. What do you notice? There's something that should stand out that's on both of those. Stress, yep. Stress. So what are some things, how could stress be modifiable and non-modifiable? Can you think of some examples? What's an example of stress that is modifiable? We've all had stress, right? Probably all stressed out right now. Right now, it's not really modifiable for you unless you drop out of the program, right? It's not a really modifiable one unless you get rid of the stress. So let's example, maybe you do some behavior modification, you do some stress relieving techniques, you're taking your long baths, or you take a long walk, anything that helps you to de-stress. But there's some types of stress for people, maybe they've lost a loved one, or job loss, things like that are they're things that are out of your control. So stress can both be modifiable and non-modifiable. So we want to take a look at these lists, but that's something that's important to remember. You'll see that again. So remember, stress can be both modifiable and non-modifiable. Risk factors, we talked about smoking and diabetes, those being two key ones for periodontal disease. Risk indicators, these are things, again, that are likely, but don't have that confirmed association. Just because you have those things, let's for instance say, just because someone is on a certain medication doesn't mean necessarily that they're going to. It could be. There's some people who it does, but it doesn't confirm it. And then the risk marker, again, is kind of your, if you have that, then get back there. Risk markers are predictors, more of a predictor. So that bleeding on probing is more of a predictor for that. Okay, so we're gonna go through these. Again, smoking is our biggie with periodontal disease. Smoking is more significant risk than even plaque control. Somebody who smokes, again, they can have the best plaque control there, but smoking is a more significant risk. Somebody who smokes is 2.6 to 6 times more likely to have that periodontal destruction than non-smokers. These people who smoke, they have more attachment loss, they have more recession, they have all of those things more so than people who do not smoke. So we know that there is that is a definite risk for periodontal disease. Remember, we've talked about refractory periodontitis cases. These are cases that don't respond to treatment, despite how well the patients do, and if they're doing everything at home, they've done exactly what you've told them to do. They needed the SRP, they got it, they've done the surgery, whatever. They've done all those things, but because they are a smoker, then that's most of the time where you're gonna have your refractory cases. It says greater than 90% of refractory cases are smokers. The effects of smoking on periodontal, or on the periodontium. We've talked about this as well. When you're doing your assessments, you're gonna notice the tissues, you know, don't necessarily look like they're that bad, right? Their pallor is a little different. The fibrotic tissue is thickened. They have reduced or absent gingival bleeding. So if you didn't know, and you're probing and looking for that bleeding, you're probably not gonna have a lot of it. But that doesn't mean that we're in a healthy state. They have that lack of BOP, but does not equate to healthy tissues. That heat and dryness from the cigarette smoking, and the vasoconstriction is what's causing that lack of bleeding. Typically, the patients are gonna have more calculus and stain when they smoke, and then smokers exhibit no difference in plaque levels. So it's not a plaque situation for these patients, that smoking has those different effects on the periodontium. And how does it work? It's because the healing is delayed, okay? It suppresses that immune response, and that's important to remember. It affects the neutrophils, which are the first line of defense, right? It interferes with the ability of the gingiva and the bone to respond to treatment. And of course, there's different byproducts. So you have subgingival, the pathogens are gonna be different. They remain on those root surfaces and in that gingival curvicular fluid, and it prevents reattachment. So that it all goes back to that healing. The ability to heal is different with patients who smoke. We looked at this almost the same picture. It might be the same picture in last week, I think, or the week before, losing track. But you have the increased melanin pigmentation. So 1 in 3 smokers will have that increased melanin pigmentation, and typically it's on the mandibular attached gingiva, as like it is in the picture. Cigar and pipe smoking. So the effects are similar to cigarette smoking. There's still those adverse effects on the periodontium. What is that we're looking at in the picture? What was that called? Smoker's palate. What's another term for it? Stomatitis, nicotine stomatitis. Remember that?
I remember.
You should remember that. All right, smokeless tobacco. We talked a little bit about this also. We have that increased inflammatory response at the placement of site. It is very abrasive, so you're going to notice more gingival recession in these areas, but typically people will place it on those mandibular buccal areas. So that's where you're going to see that tissue looking like it does on that bottom picture down there. It does contribute to periodontal disease and cancerous changes. We've talked about that before, so it's just important to remember that all these different types are going to have a response. Response to periodontal therapy. So smokers respond less favorable to therapy. Again, you're going to have less reduction. You're not going to see as much, because of the healing being affected. You're going to have less reduction in those probing depths, less attachment gains, and healing is just overall delayed. Success rates of implants are also reduced in smokers, and we'll cover implants later in the semester, but just know that it affects that as well, just because of the healing. All right, let's look at diabetes. This is considered a modifiable risk factor. But there'll be a lot, I know several of you have had patients that have come in and they'll say they're diabetic, but they're not on any medication. What is that first? Usually when somebody's kind of teetering on, being diabetic, what are the first things they tell them to do? Change the diet, exercise, right? They try to get it under control with diet and exercise. So that's how it's being modified. But when they have diabetes, their body is not producing or even properly using the insulin that's there. So there's lower insulin levels and an increase in that blood glucose level. typically you have the type 1 diabetes, which is somebody that used to be called juvenile diabetes, but that's somebody who is insulin dependent. Those patients are typically going to be on insulin. And with type 2 is non-insulin dependent. So those are usually the ones that you kind of see people develop middle age. Not always that age, but usually as somebody gets older, their body stops working the way it's supposed to. So diet and exercise is helpful for those. And then there's gestational. Have you heard, lately I've been hearing them call, there's what's called type 4. Have y'all heard that before? What's a type 4? No. So they're saying now that type 4 is Alzheimer's, and I think this is so interesting, but sugar in our body, I mean, that is such a big thing for our bodies, and as you age, it affects your brain. But I've heard a lot of people talking about them calling, that's not gonna be a test question, it's just probably something that's in research now, so it's something to know, but that your insulin and the way that your body handles the sugar and stuff can affect your brain long term, which is pretty interesting. But anyway, so the common factor for all of those is that elevated blood glucose level. That is the common denominator there. All right, diabetes as a risk for periodontitis. So well-controlled diabetics have no more periodontal disease than non-diabetics. That's important to remember. That if we can get them under control, we can get everything, get their levels good, again, by that diet and exercise, that they don't have any more periodontal destruction than others. Well-controlled diabetes, so stabilized blood glucose levels within that recommended range. As long as we're keeping them there, then the body is good. Periodontal disease is a complication of uncontrolled diabetes. And then undiagnosed or poorly controlled diabetics are at a greater risk for severe periodontitis, more so than controlled diabetics or non-diabetics. All right, the effects of hyperglycemia. So again, it's an immune response thing. So just like smoking, that's how this is working to negatively affect their periodontium. It suppresses the host immune response. And again, that neutrophil function is what is being diminished. It does lead to poor wound healing. Recurrent infections are common. That glucose-rich environment may alter the bacterial composition in plaque and influence development of the disease. So that's how that's working. But again, the big takeaway is the host immune response doesn't allow the body to heal properly. Okay, so again, uncontrolled or poorly controlled glucose levels result in increased risk for developing other infections. There are acute periodontal abscesses, more extensive attachment loss with these patients, and they have more progressive bone loss. That's what you're seeing in that picture is a abscess up there. Oral manifestations of diabetes, common complaints of uncontrolled diabetics. They have reduced salivary flows, their mouths may be dry, burning tongue syndrome, xerostomia, and that whole environment is just not a good environment. It's good for Canada, but it's not a good environment for us. So you're going to see more infections occur because of that. Again, apparently this is just a real takeaway. Similar response to non-surgical therapy as non-diabetics these ways. So we want to make sure that we're getting them well controlled. So if you've got a patient that is not well controlled, maybe we have them in and we don't have their recent readings yet, or we know that they're uncontrolled, we can at least do some of those assessments before we probe and stuff, but that's really what you should be educating them on, is making sure that we get to a controlled level and not just so you can come back in and we can see you, which we want to, but more so for their overall health, their overall response. Poorly controlled diabetics, again, poor response to non-surgical and surgical therapy. It's more rapid recurrence of those deep pockets. Then there's less favorable long-term response to treatment. Of course, you add smoking in because people do. They know that they have bad health and they still have the bad habits too. So you have somebody who's diabetic and a smoker. 20 times more likely to experience severe periodontitis than non-diabetic or non-smoker. So stacking those risk factors is really bad for your patients. Okay, let's talk about some of the modifiable risk factors. Specific pathogenic bacteria. The quantity of plaque is not as important as the quality. So we've talked a little bit about, with some patients, the need to identify what bacteria is there. Etiologic agents, we know, are those very specific bacteria. Those are important. You're going to keep seeing those over and over, so go ahead and commit them to memory. The little key on the bottom there, those stronger ones are your AA, P. gingivalis, and T. forsythia. Those are the three that have a stronger response, and then the T. denticola is more of a moderate. Microbial tooth deposits as a modifiable. Why is that modifiable? We can get rid of those, right? If we're talking about calculus or biofilm, those tooth deposits, we can get rid of those. So they do increase that risk, but it's modifiable because we can help control that. But poor oral hygiene, that increased biofilm, is going to lead to more inflammation and more destruction. So that's why we harp on these patients the need to keep that biofilm as low as possible. The quality increases in virulence over time, and the quantity increases over time. So the longer it's allowed to sit there when somebody has that poor oral hygiene, remember we talked last year about the longer it's left there undisturbed, it grows, right? It grows its little condo dimensions down there, and it's just having a party. Calculus as a reservoir for plaque. So remember, calculus isn't the key etiologic factor, but it allows even more plaque to settle there, and that's how it can be more destructive. But it doesn't impact individuals equally, and that's, again, kind of that same concept that we don't just, because somebody has the calculus, and I promise you'll probably all work in practice with some doctor at some point. This is why they've got all this calculus, but again, what we're looking at is what? The probe depths, and is there actual bone loss there, right? Yes, it's going to take you more time if somebody has a lot of calculus, but not everybody is responding the same. You may have a younger patient that has a lot of calculus there, and there's a lot of subgingival calculus. They haven't had any bone loss. We probably all had somebody in clinic at this point that is a similar situation. They might be a class 3, they have the calculus that's there, but they're still maybe just gingivitis, right? Yes, ma'am.
I actually had a patient who came back for recare, and like she went from a class 3 to class 1, and it's just, you know.
Well, and that's something too. I was talking to one of the, I don't remember who I was talking to now, but when you have a patient that is a higher class, 3 or 4, we've just cleaned them 4 to 6 weeks, right? They shouldn't still be there. They shouldn't. We've cleaned something, so something has got to have changed. We shouldn't see them come down. So that's normal. If you had a class 4 at their reeval, they shouldn't still be a class 4. So don't think in your head, oh, I had a class 4, we'll get credit for another class 4. Well, that shouldn't be the case, because you should have done well enough that there's not that much there. But again, we've talked about even the most experienced clinicians, right? There's going to be some residual calculus, and there's going to be some that start building it pretty quickly, just because that's how their bodies are. That's just their makeup. Does all that make sense? Yeah. Okay. And then the susceptibility with these tooth deposits. So the anatomic and restorative factors play a role. We've talked a lot about that with the, whether it's the anatomy of their root structure, or their concavities, different things like that are going to affect how the plaque kind of harbors in certain areas. But they have those open margins and things like that, it's going to affect that. All right, nutrition. This is something that's big that you guys are working on right now, how that affects your patients. So malnutrition, again, it compromises the host response and their defense mechanism. So when somebody is malnutritioned or they don't have the proper nutrition, it affects how they heal. It affects how they respond to the bacteria that's there. But they do have an increased susceptibility to different infections, and they may have an exacerbated gingival response to plaque. So you're going to see them with the, maybe it's not bacteria related with them, but because their nutrition, they have that exaggerated response. Primarily, these are a result of certain vitamin deficiencies, so A, B, and C are the key ones that affect nutrition. All right, alcohol. So chronic alcohol intake. Again, what is the key thing you're gonna keep seeing? So when in doubt, you probably should just go with it being an immune. If you weren't real sure, just guess that it's immune, because that's probably how it's related. But again, it suppresses the immune response. So now these patients, and we have a whole lecture on this in 4300 this semester, but these patients, if you've ever known somebody who is an actual alcoholic, I don't know if any of you have, unfortunately I have, but somebody who is, that's all they're worried about. Like it's just drinking, like that's what they want, is to drink. So they're not focusing on their health, they're not focusing on eating what they should be eating, or even eating at all sometimes. It is a disturbed neutrophil function issue. They may have increased bleeding tendency. So, and then also when you're drunk, you know, all the time, you're not worried about brushing your teeth and taking a shower and doing all those things that you should be doing. We've probably all had a drunk episode, right? Like that was not your top priority to get up and go brush your teeth, right? So you imagine being that way all the time. I don't know how people do it, but all right, stats with tobacco and alcohol use. Again, you combine the two, but what do you see? Usually, even somebody who's a social drinker, not somebody who's drinking all the time, but sometimes that just goes hand in hand. They have a drink and they want to have a social cigarette. I don't know why, but people do. But when you combine those over time, 70% of alcoholics are heavy smokers. Smokers are 1.3 times more likely to drink alcohol than non-smokers. So for some reason, it seems to go hand in hand, but you put the two together and that's just a bad combo for overall health. And of course, both of them are cancer risks, right? So you have an increased risk of esophageal and other oral cancer. That increases with heavier use. Again, we're not talking, you know, again, that's a key reason to ask, you know, how often and how much, because it is what we consider dose response. Somebody who has a cigarette and smokes, you know, on occasion, maybe once a month you go out with your friends and you have, that's different from somebody who smokes a pack of cigarettes a day and drinks, you know, whatever, vodka every day, you know, like that's different. So it's gonna affect, or it does affect based on the dose that's there. All right, different health conditions that are associated. So HIV and AIDS, there's a disproportionate amount of plaque to the degree of inflammation. So these patients, again, it is a healing issue, immune issue. They may not have a lot of plaque there, but they have a severe reaction to what is it. So that's kind of what you're gonna see. Not every HIV patient or AIDS patient is gonna have that, but again, it is a risk, you know, it is something that puts them at greater risk. Other oral tissue conditions that are very common, and we will talk more about these in PATH also, but these patients typically have more Candida issues. Kaposi's sarcoma, have y'all heard that term yet in your, okay, so we'll talk more about that in PATH also. But linear gingival arrhythmia, periodontitis, necrotizing gingivitis, and necrotizing periodontitis, all of those are things that you may see because the patient has HIV or AIDS. Osteoporosis is also another systemic condition. Anybody know anybody that's had osteoporosis? Usually it affects older women. As women age, happens to your bone density. But again, it's a loss of bone mineral. The bone becomes more porous and it decreases in thickness. The population typically is postmenopausal women, people who are sedentary, they don't move around. That's why even, you know, they say to keep moving, but even as you age, my parents have gotten to their, you know, retirement years, but my mom loves to listen to her little true crime AirPods and she'll go out and walk. She's like, you just gotta keep moving. There was somebody at the end of their neighborhood that I don't know how old he was when he died, but he was 90-something years old, and you'd see him out working in the yard and you think, oh my gosh, he's so old, but that's what happens. If you don't keep moving as you get older, you have more of a sedentary lifestyle, then that's when things set in. So it's important, especially as we get older, to keep moving and keep doing things. Also, another population that osteoporosis is common with is long-term steroid therapy. So different steroids are more common with these patients. With the postmenopausal women, it's caused by the cessation of estrogen production. The bone becomes more porous, there's less trabeculation and that thin cortical plate. So that's kind of what's going on in there. Osteoporosis and periodontitis risk. There's a possible link between skeletal osteoporosis and alveolar bone loss, interestingly. Significant correlation between mandibular bone and hip bone mineral density. So that is another interesting factor there. It does not initiate tissue destruction. So it may aggravate the progression of periodontitis, but they've got to already have periodontitis. With sufficient plaque stimulus, it can lead to severe periodontitis with some of these patients. So again, it's not gonna happen necessarily just because they have it, but if they have the right environment, then it could. Hormone replacement within 5 years may lessen the inflammation and slow the progression of alveolar bone loss. So when we're talking about somebody who is postmenopausal, they've stopped producing those hormones, so it's saying hormone replacement therapy within that 5-year period. All right, hormone alteration. So changes or imbalances in sex hormones can affect the periodontium. Different times that we're seeing changes in those hormone levels during puberty. So men can have that increased as well. Pregnancy, and then menopausal or postmenopausal. So again, women have all those times, men typically just at puberty. Hormone alteration, again, elevated estrogen and progesterone, that's what's increasing during these times. It alters the vessel dilation, so there's increased sensitivity there. There's increased inflammation and gingival enlargement. We've talked about, during times, especially when a patient is during puberty, or they're on birth control medications, or your patient's pregnant, we see that enlargement more commonly. And it's just an exaggerated response to those local irritants that are already there. So they've already got to have the bacteria, they've already got to have the calculus that's there, but it's that exaggerated response. Decreased levels of circulating hormones can cause that dry mouth, altered taste, and burning mouth. Those are 3 common things that you'll see when there's decreased hormone use. All right, different medications that affect. So side effects of a lot of these medications, that's one of the top side effects that you'll see is xerostomia, gingival bleeding, and gingival enlargement. All of those are very common side effects of different medications. Some of the drug-induced gingival enlargement that are common, you have calcium channel blockers, immunosuppressants, and anti-seizure medications. And then of course the sex hormones like estrogen and progesterone that you would see commonly with oral contraceptives. All right, local contributing factors. So we've talked in depth about all of these, but just keep in mind that those overhangs that you see, subgingival margins, orthodontics are a local contributing factor, removable partials, malpositioned teeth, different piercings that are in the mouth, calculus, attached gingiva amount, and then different traumas can all be local contributing factors. All right, modifiable risk indicator and a non-modifiable risk determinant we talked about with stress. That's all of y'all right now, right? It's me too. I'm feeling the stress with school as well. Physical and psychological, so it can affect people physically. It affects, again, immune function. That's how it's causing what it could potentially cause. Possible increased susceptibility to periodontal disease, endocrine disturbances suspected, It can occur in conjunction with depression, financial problems, social isolation. So people handle stress differently. You may have somebody who stresses out and they want to eat junk, or you have somebody who stresses out and they don't want to eat at all. So it affects everybody differently. Some people do get depression. There's, different things that occur. Again, in times of stress, neglect of self-care is common. We just talked about the diet changes. Some people eat more, some people eat not at all, or they just eat less. Increase in smoking. People that smoke, when they're stressed out, they're probably hitting it a little bit harder. Harmful habits, of course, we talk about stress being one of those key things for bruxism, so clenching and grinding is more common. The ability to manage stress. So poor coping skills, you combine that with high financial stress, it may double the risk of periodontal disease. People who have good coping skills are no more at risk than those without other problems. So I don't know why it specifically is talking about money problems, but that's not the only problem that we have, right? But the key takeaway there is somebody who has good coping skills versus not so good coping skills. So what do you guys do when you stress? When you're stressing out, do you have a stress relieving activity or something that helps you to de-stress? What are you guys doing right now? Because I know you're all stressed out. Do you like to go to the gym? So you have a good coping mechanism. Sleep. I don't think sleep is a bad one. I think sleep can be good. I feel like the older you get. You wake up even more stressed when you take a nap.
I'm driven about it.
Do you ever feel like this? I told my husband this the other day. I said, do you ever feel like you have so much to do and so much on your plate that you want to do none of it? You just want to go take a nap. That's how I feel sometimes. I'm just like, I get so overwhelmed, and then I'm just like, let me just go take a nap. That is not probably a good coping mechanism, but whatever works for you. So we know there is a correlation with stress and necrotizing gingivitis. Young college students are more at risk for that. And remember, we talked about soldiers. Do you remember the term that they call that? I hear it. Say it. Somebody said it. Remember, that got termed trench mouth, but that's necrotizing gingivitis. But it was because of all the stress that those soldiers that were going through in that environment. Smoking, of course, additional risk factor. Most patients with necrotizing gingivitis are smokers, so that is not a good coping mechanism. Socioeconomic status. Gingivitis and poor oral health are related to that lower socioeconomic status. A lot of that is because of probably lack of education and then lack of resources or the ability to go get care. But again, they're, a lot of time educating those patients and making sure that they're more aware. Because again, if you were a kid and didn't grow up going to the dentist, or mom and dad didn't teach you, the importance of it, then you just don't know. So a lot of times it's just education. Lower socioeconomic status alone does not result in increased risk after it's adjusted for other risk factors. All right, non-modifiable risk determinants. So age, the prevalence and severity of disease does increase with age. So when you have an older patient and you're looking at those boxes to check, age is because they have been prolonged to that environment for a longer period of time. So that's why age is one of those risk factors. Degenerative changes related to aging may increase the susceptibility to periodontitis. It may also result in prolonged exposure to other risk factors. So there's cumulative effects, and that's why age is a risk factor. All right, sex and gender. Males, this is one you guys get. You don't get very many of them. We say that males are more common to have, but more bone loss, attachment loss, and tooth loss are going to occur with males typically more. Poor health, OH is kind of related to that. There's higher levels of plaque and calculus with males, and differences related to preventive practices. And you can kind of relate that to when you have, especially that teenage population, for some reason, until girls get on their mind, the boys don't typically care about brushing their, like, you have kids that are like 11, 12, 13, they don't care anything about it until they get interested in girls, but, making sure that they are trying to, you know, for some reason, my boys have always been the ones, like, you brush your teeth, Liam will come and tell me, I brush, I'm like, come here, let me see. I'll touch his teeth, and I'm like, that's disgusting, go brush your teeth. Like, I don't know why it's such a big deal, but he just thinks he's too busy to brush his teeth. Last night he came and I told him, I said, go brush your teeth, and he come back and he goes, like, right in my face. I'm like, okay, I get it. Just wait, for those of you that have kids, they get real fun. Differences related to preventive practices, again, the differences in taking care of themselves at different ages. Race also is one that obviously that's non-modifiable, but African American patients they typically will have more incidents of periodontitis. Sometimes the socioeconomic status plays a role with that one. Genetics, we talked a little bit about genetics in Perio 1, but periodontitis susceptibility, there's those different syndromes and conditions that if you have those, they are more likely, one that you probably will run into a few times during your career, or Down syndrome patients. Those can be some super sweet patients, but they typically do have more periodontitis susceptibility. We mentioned that genetic marker, I'm pretty sure in Perio 1, but the genotype that's there, it occurs in 30% of that population, that having that marker puts you at more susceptibility and more risk. 67% of patients with severe periodontitis have that genotype. So that's interesting also. All right, modifiable and non-modifiable risk markers. Bleeding on probing, that is that clinical indicator of gingival inflammation. So alone, it's not a predictor for future loss. So just because we have the bleeding doesn't mean, okay, they're definitely gonna have more loss. That is just an area that we need to pay more attention to. Combined with higher probe depths, and there is an increased risk of continued destruction. So again, just because they have the bleeding, that might just be in the gingival tissue. It might not be that there is something further there, but you combine that with a higher probe depth, and then you are at greater risk. The lack of bleeding on probing is not an indicator of periodontal health. What was an example of that? Patients who smoke. So don't think, just because you're not seeing any bleeding doesn't mean that we're in a healthy state. All right, and the last one here, previous history of periodontitis. So because they've had that history, that is a good clinical predictor for future disease. It does the severe loss at greater risk for future loss, and then the free of disease have decreased risk for development of CAL and current disease. So once we get patients in that stable, you know, once they're stable, then they don't really have, that does decrease their risk for it developing. Questions with any of that?